Hi, welcome to Living Healthy, where we're here to help you make sense of a nonsensical healthcare world. My name is Dr. Barton Bishop. I'm the Chief Clinical Officer of Sport and Spine Rehab, and I'm also a board-certified sports physical therapist. My normal co-host to my left, who's not here today, is Dr. Jay Greenstein. Unfortunately, he's out dealing with some injured patients, and he'll be back with us next month. Each month, we bring a nationally renowned guest in their field of experience that's helping you to live a healthier and happier life. And this month is no different. We've got with us Dr. Al-Attar, who's a world-renowned plastic surgeon in the D.C. area, and he's here to help us figure out what we can do to better our lives.
Thank you.
Thank you for being with us.
Pleasure's mine.
So can you tell us a little bit about yourself, your training, your background, etc.?
Sure. I've actually spent almost my entire life in the Washington metropolitan area. I was born and raised in this area, and I went to Georgetown for many years, 20 years to be exact. I went to college there. I did my medical school there. I stayed there for my residency, mainly because of several people on the faculty that were truly spectacular. I did go away to New York for 1 year for my first of 2 fellowships, and then I actually came back to Georgetown, did a second fellowship with my former chairman. And then I went into private practice and joined one of the senior people in our community, who's, in my opinion, probably the best plastic surgeon in the area. And it was a pleasure to join him.
Well, that's wonderful. So, first of all, I'm a Jesuit schoolboy as well. I went to Creighton University, so a special affinity for the Jesuit school.
The best education.
That it is. This is no soapbox or anything. But what were your fellowships? What was your first fellowship and your second fellowship?
So, plastic surgeons can do a 6-year residency program where they do all of plastic surgery in 6 years. And then it's not required, but if you can go off and do fellowship training. Mm-hmm. My first fellowship training was actually in aesthetic surgery or cosmetic surgery. I did that for a year up in New York City with under the tutelage of a surgeon named Cheryl Aston, who's probably the most renowned cosmetic surgeon in the United States. He's a spectacular person. He, in my opinion, one of the best surgeons I've ever had the pleasure of meeting. And I got to work with him for a year. And then I came back down to Georgetown and did a year of breast surgery fellowship with Scott Spear, who's the chairman of Georgetown. And that was a year devoted exclusively to plastic surgery of the breast. Okay. Both reconstructive and cosmetic.
Okay. Well, wonderful. What was the driving force? For those who don't know, in medical school, you ultimately have to choose some direction. What was that driving force for you to move into plastics?
Well, it's really fascinating because at first I was not going to do plastic surgery. In fact, I was a late bloomer looking at plastic surgery. It was not until my very last year of medical school that I decided I wanted to apply to plastic surgery. It really was 2 individuals, 2 plastic surgeons that I got to know at Georgetown that were truly great mentors. And what happens is you get to know these people and you get to like these people, and then everything these people do has a halo around it. So naturally you get attracted to it, and that's what drove me into the field.
Oh, that's wonderful. And you've been in it now for many, many years, so it's been rewarding for you.
It's been rewarding. It's a lot of work, but it's a lot of fun.
Yeah, I imagine. What are the most rewarding aspects for you of being a plastic surgeon?
Well, plastic surgery is different from other fields in medicine in that we don't really have a body part that we manage. We're not like cardiac surgeons, or we're not like orthopedic surgeons that handle bones. We operate all over the body. No 2 patients are the same. And patients generally present with a problem, and you basically are obliged to try your best to solve their problem. It's a little different from other fields of medicine. We don't really do that much preventive care per se. Our mission is to go in, fix a problem, and then to let the patient go on with their lives. And sometimes this comes directly from the patient. The patient will seek you out directly. Sometimes a surgeon in another field may have some sort of complex clinical issue, and they want to turn that over to you to try to attempt to solve. So.
What percentage of your practice would you say is that type of consultation, that referral from another physician, as opposed to the patient directly seeking out?
It's about 50-50.
Okay.
About half the time the patient comes to you directly, and about half the time you get a referral from another physician.
Do you feel like the patient is helping to drive that in the physician at all, or is it truly the physician says, this is outside of my scope, it requires a more specialized surgeon of some sort?
It's interesting you say that. It's not necessarily that the other surgeons or the other physicians can't do the work. It's more a matter of it's something that we do a particular job quite a bit, and it's better for the patient, better for the other physician, and better for society for us to go in and manage those problems. And I think the best example is when dermatologists take off lesions, and dermatologists take off lots of moles every day, and sometimes those moles come back with problems. They can be cancerous, they can have other issues with them. And the dermatologists are superbly trained at closing the wounds they create. Every once in a while the wound becomes a little bit too big for them to handle, and it's simply more efficient for them to tell the patient to come and see me, where I have other techniques and other tools that I can do to get these wounds closed, rather than for them to try to spend the entire day trying to get this matter solved. It's just a matter of efficiency, matter of safety, matter of what's best for the patient.
Yeah, that's wonderful. So you mentioned that your residency was 6 years long.
Yes.
Which is quite long for a residency program. An orthopedic surgeon, generally is in the 5 years, right? And they have that year of fellowship. So you did 6 years of residency and then 2 one-year fellowships.
Correct.
Is it that extra time that allows you to have the techniques that, let's say, a dermatologist wouldn't have, or an oncologist or an surgeon of that nature wouldn't have?
Well, the problem with plastic surgical training, and it's a problem that we're grappling with at a national level, is that it's a constantly changing field. So one of the principles is that you are taught a series of approaches to taking care of people. You're taught a series of surgical principles. You're taught a series of generic techniques. And then you try to take all those tools that you have and solve the problems that you're faced with. Completely different with training in every other arena of medicine. An orthopedic surgeon, for example, is taught this is how you fix a broken wrist, and these are the 6 ways you do it, or this is how you treat a broken leg. Whereas in plastic surgery, it's such a rapidly moving field and such a rapidly evolving field. I think the best example is my chairman at Georgetown is a person named Scott Spear, probably hands down the best breast plastic surgeon in the United States. When he was in training, he told us he actually never did any breast flaps during all of his training, because back then it hadn't really been developed yet. And you're sitting here 30 years later, and he's world-renowned in it. So it is a rapidly moving field. There are many things we're doing in plastic surgery, including stem cell surgery and allotransplantation, which I probably, if you look at it, it's a sort of thing that you're never exposed to in training, but you're going to have to face it during your career. So the goal of training is more to train you to think a certain way and to have a certain core set of skills you can do.
Okay, that's wonderful. So, there are probably, in my mind, 2 real stereotypical visions of plastic surgery. One is Dr. 90210, right? And the other is Dr. McDreamy on Grey's Anatomy. So Dr. 90210 is mostly aesthetics and cosmetic surgery, it seems anyway, and Dr. McDreamy on Grey's Anatomy was mostly in reshaping bones of the jaw and the face,
Sure.
and doing skin grafts and so on. What's reality like?
Well, the reality is the same tools and techniques we use in reconstruction are used in cosmetic, which is why you see the 2 paired together. It otherwise would make no sense to have the same surgeons doing 2 very disparate fields. But it really is the same set of skills, the same assessments that you're making, dealing with a woman who's looking for a facelift versus a burn patient who burned a part of their face and you're looking to rebuild their face. It is a very identical clinical problem in terms of how we approach it. And realistically, I, like many other plastic surgeons, spend about half my time doing each of them. And as the patients come in, we deal with them, we take care of them.
Mm-hmm. So what procedures specifically do you specialize in the most?
I personally enjoy working on the breast, both cosmetic and reconstructive, so I do the entire realm of plastic surgery, the breast. And again, that's a personal interest that I have, and lots of it because the people I worked with, especially at Georgetown, were stellar at it. And it's always an experience working with some of the best people in the world, because you tend to admire them and you tend to love the work they do. And you tend to push yourself to do work there. So I do cosmetic breast work, which is breast augmentation, breast lifts. We do reconstructive breast work, breast reductions, breast reconstruction after cancer. There are some people that are born with congenital anomalies of the breast, and we try to go ahead and help those people.
I think that's an overlooked thing in society and thinking about plastic surgery, is that, you know, it tends to, we tend to think of that cosmetic piece, but when you mention congenital anomalies, you know, it could be congenital anomalies of the breast, like you said. There's a condition we deal with in physical therapy occasionally, pectus excavatum.
Sure.
You know, when the breastbone is sunken in.
Sure.
And that can be, you know, a horribly debilitating thing for breathing and so on. So there's so many great things that you guys can do with that. And you got specifically interested in it through your fellowships, sure. Specifically with Dr. Spear in Georgetown. Do you do other cosmetic procedures as well besides in the breast?
I do the entire realm of cosmetic work. I do noses, rhinoplasties, I do facelifts, I do tummy tucks, I do a lot of liposuction. It's fun to be able to do the entire realm of it, and realistically when a patient comes in, they may often have 1, 2, or 3 things they want addressed. Similarly, you can't, or I should say you shouldn't, in your career stick to one solitary thing. It's very healthy both for me and for the patient, for society, for plastic surgeons to focus on a whole realm of different things. Let me also point out that many of the advances we've had in one field of plastic surgery have come from advances in other fields of plastic surgery. For example, a lot of our advances in how to do an excellent facelift have come from trauma reconstruction after people have been in car accidents, have had fractures in their facial bones. So there is an inherent knowledge base, an inherent skill base that we build as a community, and that comes from doing the entire realm of plastic surgery. And we're encouraged to stick to the entire realm of plastic surgery.
That's good. And like you said, in your training, you're taught the principles of being a plastic surgeon. You're taught how to think like you need to. So whether it's for a reconstructive face reconstruction after a car accident, or if it's just for a cosmetic facelift, it's the principle that is overriding.
Absolutely.
That's great. So you mentioned liposuction.
Do a lot of liposuction.
Same thing as a tummy tuck? No? Ish?
Different.
Okay.
Different. Liposuction is essentially removing fat. A tummy tuck is removing the central lower portion of the abdominal wall.
Okay.
I think liposuction is a great example of where training comes in. I'll never forget when I was first starting training. I'll never forget doing a liposuction case with one of my senior surgeons and thinking to myself, this is the easiest operation in the world. And by the time I'd finished my training, it dawned on me that that's probably the hardest operation in the world. And it's one of those things where it's easy to do and so difficult to do well.
Really?
And it's true in many aspects of plastic surgery. In fact, one of my previous mentors used to always point out that you can tell who's a seasoned plastic surgeon because they have a good sense of how difficult these things are, whereas when you're starting out, it often is, oh, that's not difficult.
It seems so benign. You know, people say, oh, just get liposuction, just, you know, get some fat sucked out and you're fine. But it's not, obviously.
Well, it's ultimately a carving and a sculpting exercise. If I give you the basic tools, any person can sculpt a rock, but to go ahead and make it look good is unbelievably difficult. And a lot of it has to do with where you set your bar professionally. I think as most plastic surgeons go through training and go through the years in practice, their bar just goes up and up and up.
Wow.
And so the sense of what is an excellent result is very a changing dynamic.
Understood. And I can't sculpt anything. So you mentioned about mastectomies and breast reconstructions. When we come back, we're going to discuss prophylactic mastectomy, something like Angelina Jolie just had. So we'll be right back.
If you drive buzzed, it could cost you around $10,000. You'll face major legal fees, major fines, and steep insurance penalties. You could lose everything. Nothing kills a buzz like getting pulled over for buzz driving, because buzz driving is drunk driving.
Welcome back to Living Healthy. I'm Dr. Barton Bishop, and today we're joined by Dr. Al-Attar. So Dr. Al-Attar, we were briefly talking about prophylactic mastectomies, and Angelina Jolie was hot in the topic, hot in the news about undergoing a prophylactic mastectomy. So can you talk to us about specifically how that went down?
Sure. Well, There are a few areas that are more controversial and more probably counterintuitive than the notion of prophylactic mastectomy. It's a topic that's near and dear to my heart. I deal with a lot of patients that do have prophylactic mastectomies. I've done a lot of work on prophylactic mastectomy. And let me just tell you that my own thought process has evolved on this topic. It started out that I, like many other surgeons, were completely against the notion of a prophylactic mastectomy. We spend our entire careers trying to save tissue, trying to save as much of the human body. Most of us are very conservative in our surgical approach. I don't like to do something unless I have to. And the notion of a woman having cancer and you try to treat the cancer, the way it was working in the 80s and 90s is we were doing lumpectomies rather than mastectomies. The notion being that we take out just the cancer in a small rim of normal tissue rather than taking out the entire breast. After all, why remove the breast when you can just remove a small portion of tissue? And you move that forward to an arena where women who have no cancer are now having their breasts removed. Sounded very counterintuitive. In fact, one of my colleagues who's a general surgeon would often give this example. As you know, many women who have one breast removed for cancer have a prophylactic mastectomy on the other breast. And the rationale is that we know that down the road, once you have cancer in one breast, there is a high chance that you have cancer develop in the other breast. It's a new cancer. And my surgical colleague said, well, if you have a diabetic patient who has all these problems and has a foot ulcer, and God forbid they have their leg amputated, you would never sit and say, well, now that they've had one leg amputated, they have a high chance of having the other amputated. Why not amputate the other anyways? We would never make that argument, so it didn't make sense why we would say that for the breast. But it's a completely different story. And I think a lot of that has to do with our technology in rebuilding the breast. In the 1970s and 80s and even to the 90s, as plastic surgeons, we were very happy if we could just recreate a mound. And the notion was that if you have a shirt on, that your breast would look acceptable. Whether it's in the right place or not, whether it's symmetric to the other side, is of secondary concern. Building a mound was considered success. Today, mainly due to the efforts of a handful of plastic surgeons, breast reconstruction has come so far that the cosmetic results, the aesthetic results of how a woman looks, not only with a shirt on, but with a bra on and with a bra off, they can look so good that we can often meet the aesthetic standard of before surgery, sometimes even surpass it. So with that understanding, it now becomes a different dynamic. It now all of a sudden becomes worthwhile. A woman with a risk of cancer, we can go ahead and remove the breast, drop the risk of cancer, rebuild the breast, and have them look great. And that was just unheard of 20 years ago.
Okay, so a couple of questions in there, a couple of points in there. So the general surgeon talking about the analogy of a diabetic removing one leg after, as you're amputating the other.
Right.
If the leg was able to be rebuilt instead of amputated to look the same, act the same, and basically feel the same,
Sure.
do you think that argument, a general surgeon or someone wouldn't levy that argument?
Sure, and we're seeing that is correct.
Okay.
It has to do with the quality of the reconstruction.
Okay.
The reality is every woman in the United States has a risk of breast cancer. And that's not a trivial risk. It's about 1 in 9 patients will develop breast cancer.
1 in 9 women?
1 in 9 women, I'm sorry.
Oh, wow.
about that.
Okay, no, I'm just, wow, okay.
It's fairly high. Now, it's not even. There are certain populations of women that have a much higher risk. And I'll point 2 out. The first is women who've had breast cancer in the past. If you have breast cancer and that cancer is completely treated, you're at a higher risk of developing a new breast cancer unrelated to the first, either in the same breast or in the other breast. So women who have a history of breast cancer are at high risk. Then there's a second group, and that second group is women who have a genetic or a familial predisposition. Now, what started happening is we noticed that certain populations of women had very high risks of breast cancer. Their grandmother had breast cancer, their mother had breast cancer, their aunt had breast cancer, and the risk of them having breast cancer is quite high. We've already discovered 2 genes, BRCA1 and 2, and we can actually test for those genes. And if a woman is a gene mutation carrier, her risk of developing breast cancer sometimes can be north of 80%.
80%?
North of 80%.
Wow.
Yeah, sometimes up to 85%.
Wow.
So for a woman who's sitting here, and I'll give you the classic patient that comes in. Woman is 42, 43, says her grandmother had breast cancer, died of it. Mother had breast cancer, died of it. They both died in their 40s. She's now 42, 43. She's had all the children she wants to have. She's in a stable relationship. And she's getting mammograms every 3 to 6 months. And as you can imagine, between the time she gets a mammogram and the time she gets a normal result is a couple days full of anxiety. Now, for those patients, if they are gene tested and the gene test comes back positive, they have a very high risk of developing breast and ovarian cancer. And in fact, we are offering those women, and my understanding is that Angelina Jolie was a gene mutation carrier, we are offering those women removal of their ovaries and their breasts. The notion being that their risk of breast and ovarian cancer drops down to under 1%.
Under 1. So we take someone that has 85% risk of breast cancer and a really high risk of ovarian cancer as well. In one surgery, you remove both the both breasts and the ovaries, or are they done separately generally?
Totally up to the patient.
Okay, yeah. But you do 1 or 2 surgeries.
Right.
Obviously, they carry a risk with them. The surgery is pretty low.
Acceptable risk.
Acceptable risk, yeah. Like the risk of taking Advil or Tylenol.
Well, it's a surgery. It's a surgical procedure.
Yeah, which they happen all the time. So you do the surgery, and you can recreate the breast tissue to look almost perfectly, almost like the natural tissue. I mean,
as good as we can.
Yeah. But in other words, you make it look nice, unlike 30 years ago where it might not have, or 40 years ago where it might not have, like you mentioned before. And you can reduce their risk of cancer to under 1%.
Correct. And to put that in perspective, there's some other modalities that we can use. There's what's called medical prophylaxis. We can give certain medications to women to help reduce their risk of breast cancer. Those interventions reduce the risk by 10%, 20%, maybe 30%. We can put women on an aggressive screening trial. So in other words, rather than have your mammogram every year, there are some women that have mammograms every 3 months. The fact that it tears their lives apart is a second story, but you can put them on mammograms every 3 months and MRIs twice a year. Does that reduce the risk of dying from breast cancer? It does. But you're talking about a small difference compared to a surgical solution, which just all but wipes out the risk of cancer. It's a very attractive option.
So the mammograms are also not 100%. They don't catch it 100% of the time. They're not 100% sensitive, are they?
No, I mean, this is medicine. Nothing is perfect.
Yeah.
It's a whole gamut of imperfect approaches. Oh. But the lovely thing about a prophylactic mastectomy is there is a big difference between a woman having a mastectomy for cancer and a woman having a completely elective mastectomy. In a mastectomy for cancer, a woman's going along her normal, usually busy life, either feels a lump or has an abnormal mammogram. There's a rush to get a biopsy. There's a rush to get a mastectomy. She's rushed to see 3 or 4 different doctors. She then has to have her axillary nodes at a minimum biopsied, if not completely removed. Sometimes they need radiation. They often need chemotherapy. They often need hormonal therapy, compared to something that Angelina Jolie has, where she simply schedules something that's convenient for her, makes all the decisions she wants, has a surgery, and she's done.
Well, I mean, when you put it like you put it, it's a wonder why it has become so controversial, because it seems to just be misconstrued. It seems to just be not understood. When you put it through lowering that risk so greatly.
It depends on the person. I have had some patients that say to me, and I love counseling women. I talk to women all the time, and I often encourage them to speak about it before making a decision. So a lot of women will come and say, look, I've had family members with breast cancer. I know my risk is high, but I take risks in life every day. I mean, just driving to the store, I take a risk. I will go in and I'll have my surveillance and I'll do a monthly breast exam and I'll get my mammograms twice a year. And if we develop a cancer, if I find a cancer, we'll treat it. But I'm not interested in having surgery that's unnecessary. And then you'll have a second patient that comes in right after her saying, Every time I get a mammogram, I can't sleep for 3 or 4 days. Every time I feel a lump in my breast, I can't sleep until the physician biopsies it. And for some women, in fact for many women, the fear of breast cancer is debilitating, especially when you have a patient whose mother died of breast cancer, and sometimes those unfortunate enough to have had a sister die of breast cancer. And often it clusters around the same age group. So for example, the mom died of breast cancer at 52, the sister died of breast cancer at age 50, and now this patient's 45. Boy, it's a huge psychological burden. So it depends on the patient. For some patients it's a great option, for some patients unnecessary.
What kind of recovery and recuperation are we talking about?
It's not trivial. I personally think that the trend is, rather than doing everything at once, to do the reconstructions in steps or staged. It's analogous to putting up a building. You can put it up all at once, but you're probably better off doing it in steps. And so the first surgery where the woman has a mastectomy and has a reconstruction, the initial reconstruction, is a tough one. It's about a 2-week recovery. It's a big operation. The operation really is the mastectomy as much as the reconstruction. And then they go through a series of much smaller, much less invasive surgeries. But I often tell people sometimes it takes an entire year to finish a reconstruction. We time it on their schedule, not on some rigid schedule.
And then are there different types of implants that are used in that reconstruction?
Absolutely. So there are 2 general ways of rebuilding the breast. You can use your own tissue. You can use tissue most commonly from the belly or from the back. Or you can use a device. And when I say a device, it's because we often do it, again, in steps. I can put an implant right in, but if you think about it, if a woman's just had surgery, just had her breast removed, there's a lot of tension on the closure. I don't want to put a big implant in there. So what we often do is we put a tissue expander. As the name implies, it's an implant that's deflated at first. Put it in there, let the woman heal, and come back a couple weeks later and we can actually make it bigger. Make it bigger. It's like a small, fine needle through the skin. The skin's often numb. Make it as big or as small as they want. And that way they can later decide what type of implant, what shape of implant, how big the implant is, and spread out over time.
And it's more comfortable, I would assume, for the patient to also undergo that.
It's easier for the patient to have it done in steps. I'm a big fan of giving patients as much control as possible. And any time you divide up surgeries into smaller steps, you inherently give them more control.
That's wonderful. So this has been incredibly enlightening. I really appreciate you coming on. Where can patients reach you?
Well, I have a website, www.drallattar.com, and that's probably the best way to come through and meet me.
That's wonderful. And what hospitals do you have privileges?
So I go to Sibley Hospital. I go to Fairfax Hospital, Alexandria Hospital, and Holy Cross Hospital.
Wow, so you're all over the area.
Yeah,
you can hit people here in Montgomery County or those watching online in Fairfax County or even in D.C. That's wonderful. Well, I really appreciate you coming on. It's been enlightening, and it was a great show. Thank you very much. Thank you for joining us on Living Healthy TV. We'll be back next month with another fantastic guest, and Dr. Jay Greenstein will be back with us. So thanks.